TIP42 Part 2, brought to you by LCEUs.com. If you'll remember from our earlier discussion, working with persons with co-occurring disorders requires that you employ a recovery perspective with a multi-problem viewpoint. We have to look towards the end, towards where we want them to go, not towards the problem itself. And a multi-problem viewpoint, they have presenting issues, but we have to address many of those issues concurrently. And develop a phased approach to treatment, remembering that people's readiness for change or their motivation for change is not going to be the same for all of their problems. So you have to look at, number one, what are their presenting issues? Number two, with each issue, where do you hope for them to be, and where do they hope to be 3 months from now, 6 months from now, a year from now? And phasing their steps. Step one, what are they going to do? Their early recovery, their middle recovery, their late recovery, and their maintenance. And you need to address specific real-life problems early in treatment. For example, housing, employment, finances, childcare. All these things that are going to add stressors to our patients' lives when they're discharged from residential. There are certain essential attitudes in order to deal with people with co-occurring disorders. Number one is a willingness to work with them. Well, go figure. An appreciation of the complexity of co-occurring disorders. 1 plus 1 is not 2 when working with co-occurring disorders. 1 plus 1 is more like 6. Because the mental health and the substance abuse interact, they're often supported by other problems such as PTSD or homelessness or whatever. So you need to remember that people are multidimensional and these problems interact. You need to be open to new information and aware of your personal reactions and feelings. A lot of times we get information that just kind of goes against the grain. It's not what we were taught in school. We need to be open to that information. Likewise, you're going to work with patients that don't necessarily want to do it your way. You need to be open to that because it's their treatment, and work on your own personal feelings about why you're having such a big reaction to their unwillingness to do it your way, or why you're having certain issues of transference and countertransference going on in your relationship with them. You need to recognize your own limitations and put a high emphasis on the value of the client's input. The client knows themselves way better than you do. Yeah, you know the clinical definition, you know the DSM-4, but the client knows how they personally operationalize the diagnosis. What does being depressed mean to them? What does substance abuse mean to them? And what does recovery mean to them? You need to be patient, have perseverance, and therapeutic optimism. If you get to the point where you just know that everybody who comes through your office is going to relapse and end up back in detox, and it seems like a futile revolving door, you need to take some time off. You are going to convey that in your verbals and or nonverbals to your clients. You need to be optimistic, but not overly so. It's not a cakewalk, and we don't want them to think it is. They need to know that what they're doing is very hard work, but it's worthwhile. Use diverse theories and interventions with people not only from diverse backgrounds, but from similar backgrounds. Because just because people fall into the same cultural group doesn't mean they're going to respond to treatment in the same way. We're all individuals. Be flexible in how you approach people with co-occurring disorders. You've got to remember that one disorder may be exacerbated while another one is kind of steady state. When people have, for example, a substance abuse disorder, in early recovery, a lot of times the depression and the anxiety go way up. They may be clean, but they can't focus on fidelity squat. So you need to tailor your goals accordingly. And when they get out, their depression may be under control, but their triggers for relapse and stuff may go way up. You need to be aware and help them balance these two things and not work on one to the neglect of the other. Believe that all individuals are capable of growth. I've said this at every possible opportunity. People do the best they can with the tools they have at any given time. You don't get up in the morning and say, gee, how can I screw up my life today? People get up in the morning and say, what am I going to do today? How am I going to survive the day? It's our job to give them better tools so they can do the best they can with better tools. And you need to recognize the rights of clients with co-occurring disorders. Just like any client, they have the right to treatment in the least restrictive environment. They have the right to individualized treatment. They have all of these rights, and just because they may have a mental health diagnosis that makes it difficult for them to think clearly sometimes, or a substance abuse diagnosis and they're clearly under the influence, we need to recognize their rights and tailor treatment or hold off on creating treatment plans until they can actively participate. When you do an assessment, you want to get their background, information about substance use, and psychiatric problems. We went over this in part 1, so I'm not going to belabor it. But I will say to remember to look at both substance abuse and psychiatric problems and how those two things interact, interplay with their background. What in their background exacerbates their symptoms? What in their background mitigates their symptoms? During the assessment, you want to engage the client. Conduct a person-centered assessment that is sensitive to culture and trauma. This is not just your, okay, I've got a form in front of me and we're going to fill out things and you're going to tell me everything I need to know. It's a person-centered assessment. Listen to what they're saying. Probe further on areas that you think are clinically important. Identify other sources of information. These are called collateral sources. Doctors, family members, anyone who you can get a release from the patient to talk to. Screen and detect for co-occurring disorders. Determine the diagnosis and the symptom severity on each diagnosis. Determine the level of care. And you want to also look at disability and functional impairment. This will be somewhat assessed when you're determining level of care. If the person is functionally impaired to the point where they need intensive supervision to take their medication, to make sure they bathe and they eat, then they're clearly going to be in a higher level of care. Identify strengths and supports of the client. Identify problem areas, and then ask them how they've used their strengths to deal with some of their problems in the past. Help them see that they have strengths that they can build upon. Determine their stage of change for each problem, not just necessarily the presenting issue, the one they walked in your door for, but each problem. And that can be on any of your axes. You have axis 4 problems, housing, relationships, etc. You have axis 1 problems, potentially. Axis 2 problems, potentially. So, and medical problems, axis 3. They may be more than willing to deal with their diabetes, not so much willing to deal with their axis 1 issues at this point. And very rarely do you find somebody with a personality disorder, that's your axis 2, who's ready to do anything about that. It's worth noting where the person's at on everything. Assessment is about getting to know a person with complex and individual needs. What is a huge crisis to one person may not be a big deal to another person. So you need to learn what it means to Jim Bob that he's got a criminal history, or that he's got hepatitis, or whatever. Don't rely on tools alone for assessment. Tools, at the agency I worked at, we didn't use, well, we used two. We used the SASSI, Substance Abuse Subtle Screening Inventory, and the ASAM. And that was it. That's all we could afford. Everything else was an interview. If your agency uses a lot of tools, okay, that's fine. But tools alone don't give you a clinical picture of a human being. They give you one or two-dimensional data. You want to try to get collateral information, and even if you can't get a release to talk to Jim Bob's mom, ask Jim Bob what his mom has to say about it. What has your mom been telling you about this over the past 3 months, 6 months? What has your girlfriend or your wife been telling you? How do you see it impacting your children, etc.? If you can ask Jim Bob what his family thinks, at least it'll get him thinking about it, even if he doesn't give you a completely honest answer. Don't allow preconceptions about addiction to interfere with learning about what the client really needs. Know your diagnostic criteria, and don't assume that there's one correct approach for every person, because there's not. Some people will respond well to motivational interviewing and brief therapy. Some people need a more relaxed Rogerian approach. Some people do well in 12-step programs. This is where you need to tailor treatment to your client. And remember that empathy and hope are the most valuable components you can instill during the assessment. Yeah, you have to get all this information, but this is your time to connect with this person, to let them know that you hear them and that there is hope for getting better. Techniques. There are certain stage-specific motivational enhancements you can use. You want to express empathy. Well, that goes without saying. I think all of us probably try to express empathy. Develop discrepancy. Now, this is a little bit more unique to substance abuse. When you hear a discrepancy between what John says and what he does, or what he reports is fine and then he reports other problems in an area, bring up these discrepancies. For example, if John's wife has recently left him and it's because of his substance abuse, and he reports that his relationships are fine, bring this up. Roll with resistance. Don't corner a client in the assessment. It's generally not going to work. You don't even know this client from Adam's house cat. So you roll with their resistance. If they don't want to tell you something, paraphrase, okay, I hear that's really uncomfortable for you right now, or maybe we can come back to this later. If they tell you that they don't use drugs when you're doing the substance abuse assessment, this is another place where I always used to point out discrepancies when I was working in the Department of Corrections people. They don't use drugs. Okay. They don't have a problem with drugs. Okay. Well, then why do you have 18 arrests for possession with the intent to sell, etc.? A lot of times, in our county at least, people would get charges like that null-prost. So they say, well, it didn't go to trial, so it doesn't exist. And my response was, well, yeah, it does exist. You may not have been convicted on it, but if you're arrested 18 times for possession and related offenses, that tells me at least one of those times you were guilty. We bring up discrepancies. I ask them questions sort of like, oh golly, Columbo, when he would act sort of like a tottering old fool. You know, I'm curious, or, you know, I'm confused. Ask them questions this way, instead of flat saying, well, you're lying. Support self-efficacy. We want them to believe that they can change and believe that they can make a difference in their own lives. Present to them the concept, if you have involuntary clients, that they have certain goals they want to achieve. Number one being to get away from you. And you have certain goals that you have to achieve. Number one, to get them clean and sober. So how can the two of you work together in a meaningful way over whatever the designated time period is to accomplish your goals and also help them accomplish something that's beneficial to them? Use contingency management techniques to target specific behaviors. If you come to group 100% of the time for 4 weeks and all of your urine screens are clean, we will reduce your treatment to 3 days a week instead of 5. Use cognitive behavioral techniques such as role-playing. Practice saying no. Practice communication skills. Outline sessions with specific behavioral objectives. What are you trying to teach the client? Identify why it's important to them. It always comes back to the client saying, why do I care? Why am I here? Why do I care? It's not about us. No matter how much we want to think it is, it's about them. Use relapse prevention techniques such as a daily inventory, recovery group participation, coping skills training, and medication adherence groups and meetings when you're working with clients with co-occurring disorders. Daily inventory helps them get grounded. Where am I emotionally, mentally, physically, spiritually, socially, and possibly occupationally? Participate in a recovery group with others that are at the same phase of recovery. Continue coping skills training. We all can use a tune-up here and there. Once they master a certain set of skills, you may have them assist in teaching. Most of us who've ever tried to teach something realize that the best way to find out where you're weak is to try to teach it to somebody else. So have them help teach, have them help come up with scenarios to use in your group. And medication adherence groups. Use skill building to address functional deficits. Interpersonal skills, job skills, finance skills, whatever. When you have clients with dual diagnoses or multi-diagnoses who are in pre-contemplation, express concern about their substance use. Tell them that it's a problem. And I usually couch it by saying something like, you and I both realize, or I know you realize, that substance abuse is a problem. And then we talk about the difference between substance use, misuse, and abuse. We agree to disagree about the severity of the issues. Consider a trial of abstinence to clarify. If they say, I can stop anytime I want to, okay, prove it. Suggest bringing a family member to an appointment. Like I was talking about earlier, instead of asking Jim Bob what his mom would say, get Jim Bob to bring his mom in and let's see what mom really does have to say. Explore the client's perceptions of the problem. If Jim Bob grew up in a family where drinking themselves into a stupor was the norm for his grandparents and his parents when they came home from work at night, well, then Jim Bob isn't going to see drinking himself into a stupor every night as a problem, most likely. you need to get to know the client to understand his perception of the problem based on his, here it comes, background. Emphasize the importance of seeing the client again. Acknowledge the fact that you didn't get to know them as well as you wanted to because you had all this paperwork you had to do. But you see that there are things that you could do productively together. And set the next appointment. Don't ask them, would you like to come in again? Ask them, okay, so when are you going to come back for your next appointment? This helps if you feel this is a person who needs to be in treatment, kind of push them along a little bit. And again, for involuntary clients, develop mutually acceptable goals. When I worked in DOC, the Department of Corrections, the clients that I was working with, if they came to me, it was pretty much expected that since they'd been convicted of a drug-related felony, it was pretty much expected that they were going to do 8 to 10 weeks of group. So my hands, unfortunately, were somewhat tied the way our contract was set up. Instead of just kind of not caring, I would work with the people who came through and I'd say, okay, listen, my hands are tied. I have got to put you into group. What I can do is work with you. Number one, you're stuck with me for 8 weeks, so what can we do during that 8 weeks? I mean, I have all this training and everything. What can we do during this 8 weeks and get the county or the state to pay for you to work on? What do you want to improve in your life? We all have something we want to improve. Secondly, if you attend and you stay clean, you'll be out in 8 weeks, not 10, 12, or 16. So you can kind of dangle that carrot there, your contingencies as well as your mutually acceptable goals. If you get a client who's in contemplation, they're starting to realize they may have a problem, go through the positive and negative aspects of substance abuse. And this is really effective. My husband does this really well. He's a detective when he interviews people. Because he hears them, and he talks to them, and he listens, and he hears what's most important to that particular person. Whether it's his children, his wife, his little brother, his mama, whatever. And then he goes in with this zinger, and he says, now what is your, fill in the blank, whoever's most important to him, how do you think they feel when they see you taking drugs? Or getting arrested, or whatever? It loses a lot when you go through and explain how it's done. When you see it, it's just artwork. Watching an emotionally based interview. And there are a couple other detectives where he works that use the same style that are really good at it. But this is also what we need to do. Elicit positive and negative aspects of all of their problems. If it's something that they're doing, overeating, anger management, substance abuse, if they're actively doing something, then there is a positive aspect to it. Because again, we don't get up in the morning and say, how can I screw up my life today? How can I do something that will make me really miserable? There are positive aspects. Until you acknowledge those, the person is not going to feel heard. And then look at the negative aspects. Go through mentally. How does it affect you mentally, positively, negatively? Physically. How does it affect you socially, your friends? Occupationally, how has it affected your job? Look at the positives and the negatives. Make a list so it's a visual and it's also auditory. They hear it and they see it. Ask ask about positive and negative aspects of past periods of abstinence and remission. When you were abstinent, what led up to your relapse? What was positive about being clean and sober? What was negative? There are negatives. We have to admit that. Summarize the client's comments and make explicit discrepancies between values and actions. You say you want to be a good parent, yet you're using crack and spending the family's money until you have to pawn furniture. Consider a trial of abstinence and or a psych evaluation. If the person is really if they're really still on the border of admitting that they've got a problem. If they're in the preparation stage, they know they've got a problem. They're just not quite ready to do anything about it yet. So it's our job to kind of kick them in the butt, figuratively, of course. Acknowledge the significance of their decision to seek treatment. Acknowledge how hard it is and how you know how much courage it took to come there and yada, yada, yada. Support their self-efficacy. Help them believe that they can do it. Help the client decide on an appropriate, achievable action for each issue. So when you're doing your treatment plan, work with the client, develop an appropriate outcome, and then break it down into achievable sub-goals. Caution them that the road ahead is going to be tough. There are going to be days where they just want to forget it all and go back and say, you know, it's not worth it. They're going to come. And to be prepared for it and make a plan for how to deal with that. And finally, explain that relapse shouldn't disrupt the client-clinician relationship. If you relapse, you relapse. I'm not going to think any less of you. I would really love to see you come back and we can talk about what happened and what needs to change. If they're in the action phase, you're good to go. Be a source of encouragement and support. But remember, the client may be in differing stages of readiness for change for different problems. There's benefits and drawbacks to everything. And some things may have some hidden benefits. For example, being depressed is a pass, so to speak, for a lot of people for taking responsibility. I'm too depressed, I can't do it. Buys them a lot of sympathy, a lot of attention. Don't forget to address the positives of the negative behavior, if you can follow that. And turn that around and make sure that the desired behaviors have equally similar positives. And reinforce the importance of remaining in recovery from both problems. If you let your depression start to go, your substance abuse is probably going to come back. Likewise, if you start using again, your depression is probably going to come back. Once a client achieves the maintenance phase, you need to help them anticipate and address difficulties. Recognize their struggle with either or both problems and support their resolve. This is especially effective to do in maintenance groups. Finally, reiterate that relapse or psychological symptoms shouldn't disrupt the counseling relationship. Don't ostracize them from group if they relapse. Now, if they show up and they're under the influence, yeah, they can't come in, they need to go to detox. But if they relapse and then they come back to group, work with them where they're at because they came back. Don't let it disrupt the relationship where they have to start anew with someone else. If someone relapses, and relapse is not a part of recovery, let me say that again. Relapse is not a part of recovery. You don't have to relapse. But if you do, explore what can be learned from it. express concern to your client about the relapse, emphasize the positive aspect of their effort to come back and seek care again, and again, support their self-efficacy. Okay, so you relapse. Let's see what we can learn. What was the weakness in your relapse prevention plan? Let's bolster it up a little bit and see what happens, because you can do it. We just need to work together. Special populations: women, homeless, and criminal justice. We went through those at length in part 1, so I'm not going to belabor them again. But do remember that you should have some special things in place for each of these populations. With women, identify and build on each woman's strengths. That's true for anybody. Generally, avoid confrontational approaches. Have a strong female presence on the staff. Promote bonding among women in the program, and help them reduce stress associated with parenting. Develop programs for both women and children, and provide interventions that focus on trauma and abuse, family reintegration, and family building. Remember that when women are pregnant, if they have co-occurring disorders, they're at a greater risk for postpartum depression, and many of them cannot take their meds while they are pregnant and or nursing. Be aware of how that impacts your client and help them figure out how they're going to get through that period. For the homeless population, address their housing needs. Teach them skills for maintaining housing. Work closely with shelter workers and other providers for the homeless to identify those who are homeless, who could benefit from services, and address real-life issues. For the homeless, they're worried about where their next meal is coming from and a roof over their head. We don't need to talk about all these meta concepts. Focus on the here and now and what's meaningful and helpful. Criminal justice offenders. We need to recognize that they have special service needs, including the need for positive reinforcement for even small successes. Clarify your expectations with them regarding supervision. What is your responsibility? What's the PO's responsibility? What's the judge's responsibility? Use flexible responses to infractions. You have more or less ability to do this depending on whether you're working in a drug court system. Design highly structured activities and ongoing monitoring of symptoms for these clients. And ideally, they'll be engaged in highly structured activities, and you'll be able to monitor their symptoms, their interactions, their progress as far as interpersonal relationships, cognitive functioning, etc. Abuse of alcohol and other drugs is a major risk factor in suicide. Alcohol abuse is associated with 25 to 50% of suicides, and comorbidity of substance abuse and depression increases suicide risk. Take all suicide threats seriously. Yes, there is a component of the population who has borderline personality disorder or who is determined to engage in self-injurious behaviors, but they are not lethal. But you don't want to stake someone's life on your guess that they're not serious. So take them seriously. Assess their risk. Develop a safety plan. Refer to psychiatric intervention as needed. And develop long-term recovery plans. Some of your patients, as I said a little while ago, will have personality disorders. People with borderline personality disorder have a pervasive pattern of instability in their relationships, their self-image, and their emotions, along with marked impulsivity. So they see things as black or white, and it can switch on a dime. And when it switches, they also have impulsive behaviors, this desperate need to avoid abandonment, this desperate need to have external validation because they cannot internally validate themselves. They will become impulsive, and a lot of times that means putting themselves in positions where they will need to be rescued, such as attempting suicide, engaging in self-injurious behavior, etc. Anticipate that client progress will be slow and uneven. Regularly assess their risk of self-harm, and set clear boundaries and expectations regarding roles and behavior. This is what you can expect of me. This is what I expect of you. And be very rigid in your boundaries. They will push them. They will test them to see if you're serious. So make sure you're serious. Antisocial personality disorder involves a pervasive disregard for and violation of the rights of others, and an inability to form meaningful interpersonal relationships. These are the people that we kind of slang call sociopaths. The prevalence of co-occurring antisocial personality disorder and substance abuse is high. Now, I would caution you, just like with any other diagnosis, to look at the person, look at the length of the substance abuse, look at the person's background and history. People with antisocial personality disorder truly have no empathy. A lot of people with substance abuse problems and a history of abuse, a history of violence, especially violence to them, have difficulty with boundaries. And they're out for number one. And they may appear antisocial. They may have difficulty forming meaningful interpersonal relationships. Well, if everybody in your past either abused you or abandoned you, you probably would too. Don't be quick, please don't be quick, to slap a personality disorder diagnosis on somebody. Look at how it all interplays. How does their past interplay? How does their substance use affect how they're presenting and their ability to form meaningful relationships? If they feel like crap, they're probably really not going to want to go to meetings and form relationships with others and sit in the day room. Most people diagnosed as having antisocial personality disorder are not true psychopaths. What to do? Confront dishonest antisocial behavior. If they're being dishonest and manipulative, and they're trying to manipulate someone, especially for their own gain, call them on it. This is one of the strongest aspects of the therapeutic community. Now, a lot of your patients will not be in TCs, but it's still important outside of a TC to call people on antisocial behavior. Stress immediate learning experiences that teach corrective responses. There should be immediate consequences when there is a violation of someone else's boundaries. When they exhibit antisocial behavior, these are the consequences. Hold them responsible for their behavior and use peer communities to confront the behavior and foster change. We used to have a group on Sunday nights, which was painfully long sometimes. But people would sit in a big circle, and one at a time, each client would go into the center and sit in the hot seat. And everybody in the house would get to tell that person, objectively, appropriately, what stage of change they saw that person at, and why, and any problematic or antisocial behaviors they'd seen during the week, as well as any good things. We'd always try to start with a good and end with a good and identify the problems in between. You want to assess and correct antisocial and criminal thinking. Remember, people who are raised in an environment where antisocial and criminal thinking were the norm don't know any different. So you need to help them change their way of thinking in order to help them recover. And foster longer-term individual value change and the establishment of new peer reference groups. Who are you going to follow now? You're clean and sober. The guy selling crack on the corner probably isn't going to be your mentor. Who's your peer reference group? Who are you going to hang out with? What values are you going to ascribe to? Mood disorders. Among women with substance use disorder and mood disorders may be prevalent. Among most people with substance use disorders, mood disorders may be present. Although men are more likely than men to experience clinical depression or anxiety. Certain populations are at higher risk, such as clients with HIV, clients maintained on methadone, and older adults. Older adults are at the highest risk for combined mood disorders and substance problems. Now think about where they're at in their stage of life. Their friends are dropping off. They have probably lost a spouse. They're losing their independence. They're losing a lot of things. They're dealing with a lot of grief and trauma and stress and adjustments. They're ready. They're ripe for the development of a mood disorder if they don't have adequate social support. So you want to regularly assess people on methadone, older adults, and people undergoing treatment for HIV. It's important to differentiate between anxiety and other mood disorders. Identify commonplace expressions of anxiety and depression. For example, I just couldn't get out of bed versus I felt like I was going to crawl out of my skin. Anxiety and depression are associated with more serious mental illness. You also want to make sure that what the person's experiencing is a true mood disorder and not a side effect of some other medication, or a result of substance-induced changes due to intoxication or withdrawal. And some people will have what they call protracted withdrawal. This is especially true with benzodiazepines, where 30 days later, they're going to start going through withdrawal symptoms again. Prepare them for that. Create a plan so they know what to do. Start low, go slow. That means don't put too many expectations on right away, and start low on the medication, unless for some reason you need to start higher. If the person can make it on 50 milligrams of Zoloft, great. If they need to be increased, then you can increase them. Combine addiction counseling with medication and mental health treatment. In schizophrenia, there's no clear pattern of drug choice. With this population, what looks like resistance or denial may in reality be negative symptoms of schizophrenia. Inability to display affect would be one of your more prominent issues that comes up. An accurate understanding of the role of substance use disorders in the client's illness requires a multiple contact longitudinal assessment. People with schizophrenia display a myriad of positive and negative symptoms. Remember, positive symptoms are things that are there that shouldn't be, and negative symptoms means there's something that should be there, like affect, that's not. Clients with co-occurring disorders involving psychosis have a higher risk for self-destructive and violent behaviors, homelessness, victimization, poor nutrition, and poverty. So what do? Know the signs and symptoms of the disorder. Work closely with a psychiatrist or mental health professional on your team. Expect crises. They're going to come up. Meds are going to be off. They're going to forget to take their medication, and something's going to happen that's going to be an additional stressor. Expect crises. Assist the client in linking with social services. Monitor medication and promote adherence. Provide frequent breaks and shorter sessions or meetings. 20 minutes is good. 20-minute session, take a break. 20 more minutes. It doesn't have to be a long break, but enough for them to get up, stretch their legs, shake out the cobwebs, and get refocused. Employ structure and support, and present material in simple, concrete terms with examples, and use multimedia when possible. An ideal group would start out by having a handout which summarizes what you're going to learn in the group or what you're going to go over, has an outline, not a real detailed one, very simple and concrete. You go through that, and each point is illustrated with either an activity or a video or something. Encourage participation in social clubs and teach the client skills for detecting early signs of relapse for both disorders. Involve the family whenever possible, and monitor clients for signs of relapse and a return of psychotic symptoms. They may not want to tell you if their psychotic symptoms are coming back. If you've worked with this population before, you know a lot of the medications, even the new generation antipsychotics, are very slowing. And people may not want to tell you their symptoms are starting to come back because they may not want their dosage increased. So have an open, honest relationship and be alert for signs. ADHD is in 5 to 25% of people. Approximately 1/3 of adults with ADHD have histories of alcohol abuse or dependence, and adults with ADHD have been found primarily to use alcohol or marijuana. The client may use self-medication for ADHD as an excuse for use. The presence of ADHD, however, does complicate the treatment of substance abuse, since these clients may have more difficulty engaging in treatment and learning abstinence skills. It's important to clarify for the client repeatedly what elements of a question he or she has responded to and what remains to be addressed. Eliminate distracting stimuli such as noise and desktop items from the environment. Use visual aids whenever possible. Reduce the length of meetings. Again, 20 minutes is a good rule. Encourage the client to use organization tools, such as keep a binder, have his treatment plan in there. Treatment plans, by their very nature, are structured and can help him stay more focused and more organized. Refer the client for evaluation for medication. Enhance his knowledge about ADHD and substance abuse. And examine with the client any false belief about the history of both ADHD and substance abuse issues. The rate of PTSD among people with substance use disorders is between 12 and 34%. For women with substance use disorders, it can be as high as 30 to 59%. 55 to 99% of women with addictions report a lifetime history of physical and or sexual abuse. So you see this number jumps up dramatically. Not everybody who experiences abuse or is assaulted develops PTSD. But 59% developing PTSD, that's a significant symptom or a significant number. Repeated trauma is common in domestic violence, child abuse, and some substance-using lifestyles. People with PTSD tend to abuse the most serious substances, such as cocaine and opiates. However, abuse of prescription meds, marijuana, and alcohol are also common, not only by themselves, but in combination. When you're working with a client with PTSD, proceed slowly. Develop a plan for increased safety in case they start to devolve into crisis. Establish both perceived and real trust. Attend to behavior even more than what they say, and even more than their words. And don't question them ad nauseum about the trauma. Let them tell you about how it's affecting them today. Let them share with you what they feel they need to share. Recognize that trauma injures the person's capacity for attachment. And recognize the importance of your own trauma history and countertransference in your ability to provide effective treatment to this person. Help the client learn to de-escalate intense emotions and link PTSD and substance use. How are the two of them interrelated? Provide education about PTSD and substance use, and teach alternate coping skills to help the person cope with their PTSD symptoms. Approximately 15% of women and 1% of men in inpatient substance use centers have had an eating disorder. People with eating disorders are significantly more likely to use stimulants and significantly less likely to use opioids. Opioids tend to slow you down, make you constipated. The people that you'll often see are bulimics. You have some anorexics that'll come through, but bulimia is much more common, and there's a much stronger link between alcoholism and bulimia. A lot of people who have both disorders basically alternate. If they're not drinking, they're binging or purging. Nicotine and caffeine must also be considered when assessing substance abuse in people with eating disorders. People with eating disorders experience urges for binge foods similar to an urge for drugs. A lot of people don't like that comparison, that the urge for sugar and the urge for comfort foods is like the urge for cocaine. But if you look at the symbolic meaning of a lot of the comfort foods, the love, the security, you can see how can be a very intense craving. Think about it. When do we eat? We eat, when you fall down and skin your knee, your mama gave you a cookie. When you go to the doctor and get a shot, you get a lollipop. When you have a birthday, it's a happy time, you eat. When you have a funeral, it's a sad time. People bring casseroles and you eat. Our society is geared around eating, and a lot of social interaction forms around eating. Ergo, a lot of people equate food with love and comfort. It's important to develop a treatment plan for both the eating and substance use disorder. Conduct a behavioral analysis of the foods and substances of choice and high-risk times and situations. Employ psychoeducation and cognitive behavioral techniques for bulimia nervosa. This will help the person learn identify how they're using the food and alternate ways to get those same needs met. In summary, co-occurring disorders are the rule, not the exception. Mental health issues, especially trauma and eating disorders, may not be revealed during the initial assessment. It's important to be alert for substitute addictions. They may be not drinking or not using, but what else are they doing compulsively to numb feelings? An adequate treatment must address the person as a whole. An integrated treatment address their mental health, their substance use, their living environment, their relationships. If you take into account all of these things, you're going to be much more successful working with people with co-occurring disorders.